What is it like being a doctor to the barrio? What innovations are making the greatest impact in rural healthcare? And what role does the local government play in all of this? I'm Patricia Mirasol, a multimedia producer for BusinessWorld. In this B-side episode, I talk about these topics with Francine Nicole M. Araneta, who works as a rural doctor under the Health Department's Doctor to the Barrios program. Good afternoon, Dr. Araneta. Could you please share a little bit more about the work that you do?
Good afternoon again, Ma'am Patricia. I'm Dr. Francine Nicole Araneta. I'm Doctor to the Barrio, Batch 39 President. So I'm currently deployed in the municipality of Lemery in the province of Iloilo. So actually, I'm from Iloilo City as well. So it's kind of easier for me that I've been deployed in the same province. However, it's still a little bit far from home. So I usually stay here during the weekdays and then I just go home on the weekends.
Could you also please share a little bit more about the Doctor to the Barrios program?
Doctor to the Barrios are actually a program that was created by the DOH back in, I think, 1993. It was under Secretary Flavier, wherein they created, I think, a survey wherein how many municipalities had doctors in their areas. And there was like, I think, 200 plus municipalities na walang doctors in their areas. So they created this deployment program under the Department of Health in order to address the problem of the doctorless municipalities. So kami po, as a doctor to the barrio, we act as an all-around physician actually here in our areas. We are clinicians, we are researchers, we are social mobilizers, we're educators, and at the same time, we also create policies here. So it's not only the usual doctor scene that you see na clinical lang po lahat. So it's everything, and then we usually handle a certain municipality for our entire contract. So I'm here. I've been deployed here since January 2022, and I'll be ending my contract na din on January 2025. Currently, yung batch namin, we are 153 doctors. Yung batch 39, I think batch 40 is around the same number. Pero yung batch 41 is a lot more than us because there's a lot, mas marami silang DOH scholars. So I think they're like times 2, mga around 300 na. So in total, that makes us like around 500 to 600 active Doctor to the Barrios right now in the entire country.
Are all doctors under the Doctor to the Barrios program also DOH scholars? And are all DOH scholars supposed to render compulsory service afterwards?
It doesn't mean that if you're a doctor to the barrio, you're only a DOH scholar. So meron po kaming mga walk-ins din. But in my case, I was a DOH scholar during medical school. So in our contract, we have a return service agreement that we need to comply with. So for example, for every year that I attain the scholarship, I have 2 years of return service agreement, which starts with being a doctor to the barrio. So for example, for me, I was a scholar for 3 years. So I have 6 years worth of return service agreement. So the 3 years is already a doctor to the barrio, and I still have remaining 3 years that could be done under the government as well. So yun po yun. Pero meron po kaming batchmates. Currently may batchmates kami ng mga walk-ins lang naman din. Walk-ins meaning they would deploy, you apply mismo po sa DOH that you want to be a doctor to the barrio, and then they would deploy you to those areas na wala talagang doctors din. So in our batch, marami pa rin din yung mga walk-ins. However, sa mga succeeding batches po, medyo konti na lang po or hindi na sila pumapayag na mag-walk-ins kasi they have to prioritize the scholars already.
Tell me about your experience so far as a doctor to the barrio.
In our school, we were already taught that you need to do a kind of holistic approach for our patients. It's not always about looking at the disease itself, but you have to look at the patient itself. So I was able to apply that concept here in the barrios, wherein you're not only treating the patient or their disease, but you have to think about their socioeconomic profile, their demographics. Can they be able to afford the treatment that you're giving them? So I've already anticipated things like that. However, when you get here and then you realize that resources are really limited, and then you think that you know how poor people are, when you get to the barrios, you really see how far off reality can be sometimes, or how far off things are for other people. So I think that was one of the what do you call this, kind of frustration, or something that was very challenging for me to provide treatment, to provide management for the patients with only a limited resource with me here.
You mentioned limited resources. Does the DOH help in that department?
There's already the devolution transition plan. LGUs are mandated to create or to allot the budget for each department that they have. So in terms of the DOH, since even though it's already we're following the devolution type of healthcare system, there's still resources that comes from the central office and from the region. However, it's not all. For example, essential medicines should be procured by the local government unit, but the DOH also gives medicine, especially for those areas that, for example, have epidemics or immediate need of assistance. For example, right now, there's an outbreak of dengue cases. So Iloilo is actually one of the provinces that has already been announced as one of the provinces that is under the state of calamity because of dengue. So DOH provides additional support for that. For example, they would ask us if we have enough testing kits, enough medications that we can get to our patients. So yes, they give in that aspect. However, for the year-round budget and resources, it should be the LGU's prerogative to give out these essential medicines. And for example, for the equipment, or let's say for example, for laboratories, the DOH usually gives equipment also and reagents, needed kits. However, again, since because of the the devolution transition plan, it still should be under the LGU, who does the procurement, who provides for the sustainability of the said facility.
So what I'm hearing is that health resources are also dependent on the LGU.
If the local chief executive prioritize health, or health becomes one of its priorities of the LGU, you would really see the change. You would really see how healthcare would how healthcare would improve in a certain LGU. We have a co-DTPB wherein their LCE, or their mayor, is actually a doctor. So of course, one of their top priorities is health. So what they did is that they created a financing scheme on how they could maintain the sustainability of free medicines in their area. So they have a lot of patients that usually go in their area, but at the same time, all of those patients could be catered for, and all of the patients could be given medicine from the budget of the LGU. But in my case, our LCE here also acknowledges the need for prioritization of healthcare, which shows that which can also be seen, like for example, it is easy to create certain policies, certain requests for healthcare, because they can also see how important it is. So as a TTTV, it is also our responsibilities to lobby these policies, to lobby these prerogatives, these requests to the LCE, in order for them to actually invest in healthcare and put it in paper, put it in writing, so that it would be implemented and sustained in the municipality.
Let's switch a little bit to health innovations. How is innovation being practiced in rural healthcare?
One of the innovations that DOH has been doing, which is very helpful, especially for geographically isolated areas, is that they have these mobile health units. Like, for example, they have a DOH dental van, DOH X-ray van, mga ganun po. So these mobile clinics are actually equipped with essential services, like for example, dental, oral healthcare, x-rays, laboratories, and they usually go to these geographically isolated areas and supply these health services. For example, in our area here, we've been tapped multiple times by the DOH to do the DOH X-ray caravan so that we could be able to have an active case finding of tuberculosis, which was very helpful because for example, if you live in a geographically isolated area, for example, here in our municipality, a one-way fare going to the poblacion here in our rural health unit is around 500 pesos, 500 to 600 pesos. And that's one person only, and that's one way. And then in our municipality, we don't have radiologic services here, so they have to go to the next town. So that's another 50 to 100 pesos one way. So people would opt not to seek medical care sometimes because their fare is much more expensive than what they have to buy for their medicine. So these mobile health units were actually very helpful, even though we can't sometimes go to a certain barangay po talaga kasi sobrang malayo or sobrang you have to pass by a river or parang mga ganon. At least they could go to the nearest barangay, which is accessible for them, which is at least lesser expense also for them, which is also what we do as DTTBs, why we do community visits, barangay visits, because we have patients who are bedridden, stroke patients, Parkinson's patients, mga ganun na hindi na po talaga makakalakad. I actually have this patient where I do a house visit, but they're located in a very, very far barangay na you have to pass by a medyo narrow cliff going to their house. So imagine if they have to seek medical care during emergencies, it's not very feasible because the patient is unable to move anymore. So we would usually do visits na lang for them to be less hassled din and to be safe din po for them. Another innovation I think for me is really a very big innovation is how the DOH and provincial health offices have continuously created programs for barangay health workers and barangay nutrition scholars. So aside from us here po sa rural health units, we have our counterpart barangay health workers. These barangay health workers and barangay nutrition scholars are considered as community health workers, but technically they're not really hired as a BHW, as a BNS. It's usually the BHWs and the BNS are those that are from that barangay. And it's in the prerogative of the barangay if they will be given allowance or not. But at the end of the year, they're usually given by the local government unit. But with several training sessions, these BHWs and the barangay nutrition scholars, they're very empowered to continue the delivery of primary care services in the barangay level because for example, in our municipality, we have a total population of 32,000 people. So if the doctor alone or the nurses alone do their jobs, like for example, in prenatal checkups, immunizations, we can't do it naman without the help of the barangay health workers. And they have been very helpful then because especially for those who are far off barangays, they would be the ones who would contact here to rural health unit to ask for a sort of telemedicine consult for those patients that can't go here. So another innovation that I have seen is very helpful is the inculcation of a public-private partnership or those helps from NGOs because the collaboration between the government and private sector has really led to an improvement in the healthcare delivery. For example, here in a rural health unit, our rural health unit was renovated by the BDO Foundation. It's not only here, actually a lot of RHUs here in Western Visayas is being renovated by BDO Foundation, which is a very big help. Kasi I'm not really sure because when I arrived here, it was already renovated. But stories from the staff here would say that before the renovation, sobrang hindi daw talaga conducive for a clinic yung ibang areas dito. So because of that, because of the public-private partnership, it was a very big help for the infrastructure. Also, we also partner with non-government organizations. So, for example, here in our rural health unit, we partnered with Negrense Volunteers for Change, or NVC. And this organization is actually an organization that has a vision to alleviate malnutrition. So they chose our community, our municipality, as one of their recipients, and they actually provided a year-long supplementation, food pack supplementation for our 100 malnourished children here. And imagine it was a year-long program. So hindi naman po lahat ng mga bata na alleviate from malnutrition, but at least more than 50% were really helped because of it. So you could actually see na yung mga ginagawa ng mga ganitong partnerships, they really impact yung outcomes ng mga bata. So we recently just concluded this August, and yun nga po, at least mas around 60% or 70% were alleviated from malnutrition, which is a very big number. Aside from those things po, yung mga ginagawa din po namin dito, for example, ako po as a DTTV, since yun nga po, meron pong supplementation na binigay yung NVC, during Nutrition Month, like the Nutrition Month last year, Nutrition Month this year, we would have this cooking contest using that kind of supplementation. Tapos, we created into a cookbook so that we could distribute it to the recipients, the mothers, the barangay nutrition scholars, so that they could also use it in preparing meals din po for their children. Kasi sometimes, yung problem po is they would be given this, they would be given that, tapos hindi naman po nila alam what to do with it. So we actually created a cookbook that could be used, and it was very helpful because they used it from the start last year until this year. So at least hindi naman pare-pareho yung kinakain ng mga bata. Kasi minsan kasi yung mga bata, medyo picky din, even if there's and especially if dalagyan ng supplement. Yung iba kasi they don't like the taste of the supplement, so they have to inculcate it with the food that they're cooking. So I think that's one really big innovation that we did here na I think had a very good health outcome.
I'm very impressed by the cookbook idea. How were you able to fund that?
I just compiled the list of the recipes of the barangay nutrition scholars and the caregivers that joined the contest. And then, we just printed it here in our RHU. Kasi, tsaka, linagyan na lang din namin ng point na parang in vernacular na din siya, yung ibang parts, so that they could also understand it. It's actually, that's why you might think din po sometimes na innovation doesn't really need to be that much funded, that much, with big resource, because sometimes the innovations are actually just right in front of us and we just need to do something about it lang po.
Congratulations on that. I think that was a really good idea. By the way, I wonder if you also have any thoughts about how the DTTB can help address brain drain?
Healthcare personnel also actually want to stay in the country. We also want to serve the country din. However, yun nga po, there's really a big disparity in terms of working environment, workload, incentivization, and opportunities for career development, which is actually much more evident sa ating mga nurses kaysa sa physicians. However, in the HRH policy brief that was done by the USAID, which DOH also knows of, they were able to actually recognize these gaps and problems, the root causes of the problems and why there's a brain drain in the country. And yun nga po, siguro, since they've already recognized the problems, maybe they could create solutions. And I think they're creating the solutions na din. We've released the HRH policy brief and the 8-part agenda of the DOH, which addresses din yung mga working environments at career development programs ng mga healthcare personnel. For the DTTB also po, as a way on how to avoid the brain drain, it's actually a very good program. And actually, a lot more want to try to become a DTTB. Yun nga lang po, it's also limited din yung slots. So I think DOH can create a way on how to add more doctors sa barrios na parang kahit hindi po DOH scholar. That would really, really help in the brain drain of physicians din po. Since I think yung problem po dito ng brain drain in physicians is that um, if you want to be a clinician, for example, you have to go into residency training, mga specialty. Tapos the same problems pa rin po. Kulang yung incentivization, kulang yung hindi maganda yung working environment, overwork yung mga doctors. So, yun nga po, they've already identified what are the problems and why the brain drain is evident in our country. So I think solutions can be made already for this then.
Innovations in healthcare such as mobile clinics have been a really huge help for healthcare delivery in geographically isolated and disadvantaged areas, according to Dr. Araneta. She also pointed out that the priorities of local governments have a role in improving the health and well-being of patients in those areas. This has been another episode of B-Side. Subscribe now and enjoy insights on Philippine business and beyond.